right, good morning. Good morning. Welcome to my channel. This is Patrick. Today we are going to discuss 50 cardiology questions that you must know. So these questions are very simple and they are very short. Okay, so let's get started. Question number one. What is the definitive treatment of cardiac tamponade? Okay, again, what is the definitive treatment of cardiac tamponade? Before I review the answer, it is important that we understand what cardiac tamponade is. Cardiac tamponade is when you have excess accumulation of fluid in the pericardial sac. So a question is asking, what is the definitive treatment? So the definitive treatment is pericardiocentesis, and all what that is the removal of those excess fluid that accumulated in the pericardial sac. All right, so that's the answer, pericardiocentesis. Question number two. When you auscultate a patient, you hear a harsh systolic murmur along the right sternal border, and this murmur radiates to the carotid. What is the most likely diagnosis? All right, so again, let's dissect this question a little more. So someone comes to your office, a patient comes to the hospital, you auscultate the patient, and on auscultation, you are hearing a harsh systolic murmur along the right sternal border, and this murmur is radiating to the carotid. What is the most likely diagnosis? I'm going to give you a minute to see if you can figure it out. All right, this is aortic stenosis. All right, this murmur is aortic stenosis. Next, you have a wide pulse pressure with a blowing diastolic decrescendo murmur at the second intercostal space. What should you think about? This should make you think of what diagnosis? So again, a patient comes in, you auscultate the patient, and you are hearing a wide pulse pressure that is blowing in a diastolic crescendo manner, right? So a wide pulse pressure with a blowing diastolic crescendo murmur, and it's located at the second intercostal space. What should this make you think about? So this is aortic regurgitation. All right. Next, what two antibiotics? All right, what are the two antibiotics that you can use to empirically treat endocarditis? Two antibiotics that you can use to empirically treat endocarditis. The answer is vancomycin and ceftriaxone. Next question. You perform an auscultation on a patient and you hear a harsh, blowing, pan-systolic murmur at the apex. What is the most likely diagnosis? Again, you perform an auscultation on a patient and you hear a harsh, blowing, pan-systolic murmur at the apex. What is the most likely diagnosis? The answer is mitral regurgitation. You suspect mitral regurgitation. What is the most accurate way for you to confirm that this is the diagnosis? So in your differential diagnosis, you suspect mitral regurgitation. How do you most accurately confirm your suspicion? The answer is transesophageal echocardiogram. Next question. You have a 65-year-old patient who is presenting with severe back pain. He also has dizziness, and on physical examination, you notice hypotension. When you palpate the abdomen, you can appreciate a pulsatile abdominal mass. What is the most likely diagnosis? All right, so we have a 65-year-old patient, and this patient is presenting with severe back pain. This patient also has dizziness and hypotension. You do your physical examination and you can appreciate a pulsatile abdominal mass. The question is, what is the most likely diagnosis? The answer is ruptured aortic aneurysm. All right, so the triad of aortic aneurysm is a severe pain that radiates to the back, hypotension, as well as pulsatile abdominal mass. When you see those three things, it is aortic aneurysm until proven otherwise. Next question. What are three things that could constitute a positive stress test? So let's say someone has angina, which is chest pain, right? A patient has a stable angina and you want to do a cardiac stress test. What three things will constitute a positive stress test? So you can have an increase in chest pain, right? So this person has an unstable angina. You put them under stress. A positive outcome could be an elevation in their chest pain, an increase in chest pain. You could also see a drop in blood pressure, or you could appreciate new arrhythmia. So those are three things that you can look for that will tell you that you have a positive stress test. Next question. What is the initial treatment of myocardial infarction? What is the initial treatment of heart attack? So there's something called MONA, okay? And that is morphine, oxygen, nitroglycerin, as well as aspirin. So when someone has a heart attack, that's the treatment, okay? You want to give them morphine, oxygen, nitroglycerin, and aspirin. Next, you look at a patient's EKG and you see a narrow QRS. The heart rate is regular with 200 beats per minute. What is the most likely diagnosis? Again, you look at a patient's EKG and you see a narrow QRS. The heart rate is regular with 200 beats per minute. What is the most likely diagnosis? The most likely diagnosis is supraventricular tachycardia. That's your answer. Supraventricular tachycardia. Next question. What is the most common cause of acute endocarditis? When I was doing my internal medicine clinical rotation, I got a question on this. The most common cause of acute endocarditis. You need to know that. The answer is Staph aureus. Okay, that's your answer. Next question. What is the most common pathological murmur in childhood? Okay, the most common congenital, or the most common pathological murmur in children. That is VSD. Yes, that is VSD. Sorry, this is a mistake. It's not ASD. It is VSD. Okay? Make sure you correct that. It is ventricular septal defect. Next question. So you're looking at a patient's x-ray, chest x-ray, and you see a 3 sign with notching of the ribs. Okay? You are reviewing a patient's chest x-ray, and you see a 3 sign with rib notching. What is the most likely diagnosis? This is coarctation of aorta. Okay? This is coarctation of aorta. You're probably watching this and you're wondering, what is coarctation of aorta, right? I'm going to explain. So, coarctation of aorta is when you have the narrowing of the aorta. Okay? Aorta is the largest artery in the body, right? So when that artery begins to narrow, especially at the distal end of the left subclavian artery, that is what we call coarctation of aorta. And how do you know that the patient has coarctation of aorta? When you do your physical examination, you're most likely going to appreciate an increase in blood pressure in the upper extremity. And you're going to see a decrease in blood pressure in the lower extremity. Now, in a normal patient, in a patient who does not have coarctation of aorta, this should not be the case. Okay? So in a patient who does not have coarctation of aorta, the blood pressure in the lower extremity should be higher than the blood pressure in the upper extremity. But when you have coarctation of aorta, the reversal is the case. You now have a situation where the blood pressure in the upper extremity is increased, while the blood pressure in the lower extremity is decreased. That should not be the case in a patient who does not have coarctation of aorta. Moving on. You auscultate a 3-day-old infant. Okay, this patient was born 3 days ago. And you do an auscultation on this patient. And you are hearing a continuous machine-like murmur. What is the most likely diagnosis? The answer is patent ductus arteriosus. We call that the PDA. That is very classic. In an infant, you auscultate the infant and you hear a continuous machine-like murmur. That is PDA, patent ductus arteriosus. Next question. What is the most common risk factor of PDA? What is the most common risk factor of patent ductus arteriosus? And what is the most appropriate treatment? The most common risk factor is prematurity. So when these infants are born as premature babies, that's the most common risk factor of PDA. Okay? You know, prematurity is when you have a child anytime less than 36 weeks. That's considered premature. So that's the number one risk factor of PDA. It's prematurity. And the treatment of choice is endomethacin. You need to remember that. This is high yield. This is very commonly tested. Next question. You hear a loud, harsh pulmonary murmur along the left sternal border. What is the most likely diagnosis? Again, you auscultate a patient and you hear a loud, harsh pulmonary murmur along the left sternal border. What is the most likely diagnosis? The answer is ventricular septal defect. Ventricular septal defect, VSD. Remember, this is the most common pathological murmur in childhood. Next question. What is the most common location of aortic aneurysm? Where are you most likely to find aortic aneurysm? The answer is in the abdomen, especially below the infrarenal arteries. So, aortic aneurysm is most commonly located in the infrarenal arteries in the abdomen. So, which gender is more at risk of having aortic aneurysm? Which gender is more at risk of having aortic aneurysm? Is it males? Is it females? The answer is males. And the screening recommendation is if you have ever smoked and you're a male and you're 65 and above, you need to be screened. And the screening of choice is abdominal ultrasound. Next question. What is the most common risk factor for aortic dissection? And if you haven't already, I encourage you to watch one of the videos that I posted early on. In that video, I made a distinction between aortic aneurysm and aortic dissection. It's a beautiful watch, okay? Because those two conditions are always being confused. They sound almost the same, right? One is aortic aneurysm, one is aortic dissection. All right, so the previous question we talked about aortic aneurysm, but this question is asking what is the most common risk factor for aortic dissection? The answer to that is hypertension. Hypertension. Okay? It increases your chances of having aortic dissection. So now you have a patient who is presenting with a tearing chest pain, right? A tearing, they describe this pain as a tearing chest pain, which radiates to the back. And when you check the blood pressure, it is seriously elevated. What is the most likely diagnosis? All right, once again, this patient has a chest pain that is very severe. They are describing it as tearing chest pain, and it radiates to the back. You measure the blood pressure, it is pretty much elevated. What is the most likely diagnosis? The answer is aortic dissection. Okay? And this is very important. So when you read a clinical vignette, they're going to give you all kinds of information. But you need to have the ability to recognize pertinent information versus information that is simply put there to distract you. So when you suspect aortic aneurysm, you need to listen or read how the patient is describing the chest pain. Does it radiate to the back? Do they describe it as very severe chest pain or a tearing chest pain that radiates to the back? And if you see that they have a seriously elevated blood pressure, that is aortic dissection until proven otherwise. And the medication of choice is beta blocker, esmolol. Okay, that's the medication of choice. Next question. What will a chest X-ray show in a patient who has aortic dissection? So again, you suspect that this patient has aortic dissection. You get a chest X-ray. What are you likely to find? The answer is widened mediastinum. All right. So again, when you're making a diagnosis, it's like solving a puzzle. You do your history, right? You ask patient, what happened? What brings you to the hospital, right? When did it start? How long has it been going on? Is it constant? Does it come and go? Right? Is it worse in the morning or at night? Certain diseases are worse at night. Right? So you do all those things. You try to understand the severity. In the case of aortic dissection, they're going to describe it as a very severe chest pain. Another thing you want to appreciate is it located on the same side? Is it located on one side, on the same place? Does it radiate? Does it move? So in the case of aortic dissection, it has a tendency of radiating to the back. So that's number one thing. You listen to the patient. That's when you take your history. How are they describing the symptom? Then you do your physical examination, which is objective. What the patient is telling you is subjective. It may or it may not be true. Objective is what you, as the provider, what you find. And that will basically support your suspicion or what the patient is telling you. And then you can do lab and do imaging to prove, to confirm what you think. That's how it works. So in this case, you suspect aortic dissection. You get a chest X-ray. What are you likely to see? You're likely to see widened mediastinum. Next, what is the best test to diagnose aortic dissection? The answer is CT, a CT scan. Now you can do other things. You can do, like I mentioned previously, you can do a chest X-ray. But this question is asking you the best test to do, and that's a CT scan. Next question. What are the 6 P's of limb ischemia? So when you suspect that someone has limb ischemia, right? Ischemia is when you are not getting enough blood supply to an area. So when there's limb ischemia, what are the 6 P's that you're likely to see? The answer is pain, paresthesias, pallor, pulselessness, poikilothermia, and paralysis. As a matter of fact, I had a question on this, and the question was asking, which of these P's are you going to see in the early presentation? So it's not enough for you to know the 6 P's that are associated with limb ischemia. But which of the 6 P's do you see in the early onset of limb ischemia? Which one do you see as a late presentation? So in the early onset, you're most likely gonna see things like pain, right? And then late presentation could be things like paralysis. and loss of motor function. Very important that you remember that. Next, you have a patient who is presenting with calf pain, right? The patient has pain on their calf. And this happens when they are walking, right? They're taking a walk at the park, they're exercising, and they're having pain on their calf. But this patient notices that when he or she sits down, right? When the patient sits down or when they are resting, the pain goes away. They come to you as a provider. You do your ABI, which is your arterial brachial index, and you measure the pressure, and you're getting 0.85. What is the most likely diagnosis? This is a very common question that they ask. What is the most likely diagnosis? The answer is peripheral arterial disease. So when patient is walking or exercising and they feel pain on their calf, there's a special word for that. We call it claudication. Okay? And they're going to tell you that when I stop exercising, the pain goes away. When I stop walking, when they take a rest, the pain goes away. But when they start walking, they have a calf pain. And this is so classic that if they walk up to a certain mile, that's when the pain starts. So that is peripheral arterial disease. And how do you treat this? The first line treatment is a supervised exercise. That's the first line. Supervised exercise. If that doesn't work, then you get into medication. And this is the case with most medical conditions. The first line is always going to be non-pharmacological treatment, right? For example, if you're newly diagnosed with hypertension, what are they going to ask you to do? Change your lifestyle, right? They're going to introduce you to DASH diet, right? They're going to prescribe exercise, right? Going to ask you to eat diet that is low in carbohydrates, that is low in fat, that is low in sugar, right? And you do that for a certain period of time. If it doesn't work, now we're going to put you on medication. That's how most medical conditions are approached. So next question. Giant cell arteritis is most commonly associated with what medical disease, with what medical condition? Okay, so there's this thing called giant cell arteritis, right? You usually see it in patients who are maybe 50 years and above, okay? And they have headache and they might have jaw claudication, okay? So they might have pain when they're chewing, and then you do labs test and you see elevation of ESR, okay? Or you do lab and you see elevation of C-reactive protein, right? So that is giant cell arteritis. Some people call it temporal arteritis, okay? So it doesn't matter what you call it, but this question is asking giant cell arteritis is most commonly associated with what disease? It is most commonly associated with what we call polymyalgia rheumatica. And again, this is very commonly tested. So giant cell arteritis is most commonly associated with polymyalgia rheumatica. Next question. What is the gold standard for the diagnosis of giant cell arteritis? I've seen this question multiple times. What is the gold standard for the diagnosis of giant cell arteritis? Again, it's important to know the gold standard is different from initial step that you're going to take, or initial testing that you're going to do, or initial imaging that is available. Sometimes depending on the clinic or the hospital where you work with, right? You're going to find out that gold standard is not always the most commonly used option, because sometimes the gold standard might not be available, it might be invasive, it might be very expensive, and so on, right? But gold standard is gold standard. That means if you really, really want to nail the diagnosis without any shadow of doubt, then you have to do it. So in the case of giant cell arteritis, the gold standard for diagnosing giant cell arteritis is temporal artery biopsy. Okay? That's very important. You need to remember that. All right? So when you look at the EKG, this is another question. When you look at the EKG and you see a sawtooth pattern on the EKG, so this patient is probably presenting with things like palpitation, dizziness, lightheadedness, and you get an EKG to know what the etiology is, right? And when you're reviewing the EKG, you see a sawtooth pattern on the EKG. What is the most likely diagnosis? This is a flutter. Okay, this is arterial flutter. So at this point, I'm gonna say thank you for again always making out time to follow my channel, watching. I encourage you to subscribe, like, and share the video. Okay, I'm gonna be churning out as many videos as possible. Do leave me a comment, let me know if this is helpful, and again, I appreciate you guys. All right, thank you so much. Stay healthy and stay blessed.